The next speaker is Dr. Abdul Bachani, who is the Associate Director for our Injury Unit and also an Assistant Scientist in our Department of International Health. He's going to talk about the monitoring and evaluation of our Global Road Safety Program, some common key lessons that we learned.
Thank you, Shivam, and good afternoon, everyone. So as you all heard this morning, we have been involved in a 5-year project to address road traffic injuries in 10 countries. And one of our primary mandates as part of the group of partners in this consortium was to monitor and evaluate the work that was being done to see if we're having an impact both in addressing risk factors as well as reducing the number of crashes, injuries, and fatalities. Now, as you can imagine, working in 10 countries comes with its own sets of challenges. Each country is, you have your own settings, you have your own challenges, each country comes with its own strengths as well. So what we thought we would do is have this session where we talk about what we've learned through this process over these last 4 years and 9 months in terms of lessons that can be applied for the future as well. So through the next 15 to 20 minutes, what I'm going to do is I'll provide a brief overview of the data collection options that were available to us and the data options that we employed in some of our work, and then go through some of the lessons that we've learned and using specific country examples. I'm going to focus primarily on 2 countries here, Kenya and Cambodia, because those are the countries that I was intimately involved with. And I'm going to finish by discussing some of the strengths, challenges, and barriers to the M&E work that we had. So let's first talk briefly about the state of data collection. As you know, with any work that we do in this field, we have 2 options available to us. We have secondary data that's available in many of these settings already, data that has been collected for other purposes, not entirely for the purpose that we want to use it for. But each country had multiple data sources, and we also conducted a literature review to be able to understand the field of knowledge that was generated around each country and each risk factor. But secondary data sources, as I said, are not, they're data that have been collected for other purposes. And therefore, most of these data sources lack consistency within countries and across countries. We faced definitional variations, so variables were defined differently, as well as multiple indicators or contrasting data sets, and we found it difficult many times to access some of these data sets. And therefore, for our monitoring evaluation work, we also implemented some primary data collection options. And this allowed us to standardize our data collection across countries and across different methodologies, which allowed us to have some consistency across of indicators. So we had consistent indicators across these countries, as well as definitions of these indicators, which is extremely important. Some of the options we had available to us were observational studies, which we conducted to understand the prevalence of risk factors and how those were changing over time. We also employed roadside interviews, in-depth interviews and focus group discussions, hospital-based surveillance, as well as population-based household surveys. Here's a table that you saw this morning as well. These are all the different data collection options that we used in the different countries, in all the 10 countries represented here. As you can see, in some of the countries, we were able to implement more types of data collection activities. In others, fewer options were available to us. And that was mainly because of the costs involved with these activities, as well as permissions involved and the local landscape. So with that, I am now going to dive right into some of the lessons that we've learned. And so first, I'm going to start with secondary data. we found, and I'm going to use the example for Vietnam in this case, and we found that when we're trying to use secondary data, it's very important for us to be able to understand what each source is giving us. So the more common secondary data source options for us for our work are usually police data when you want to find information on crashes or injuries. Hospital data is, as most of us know, pretty good for data on road traffic injuries or deaths. We found in some cases we had access to national surveys, which had some pretty detailed information. And in the case of Vietnam, we had a very good commune-level vital registration system. As I said, each data source has its own strengths and weaknesses. Now, when we were trying to monitor mortality in Vietnam, we first started with hospital data because that was available to us and that was a natural place for us to go initially. But we were finding that the number of deaths we were getting in our data were very low, lower than what we would expect given the rate of road traffic injuries we were seeing in that country. In talking to people and our local collaborators in Vietnam, we found that the culture there dictates that if someone is about to die, that they be released from hospital so that they can die peacefully at home. And therefore, these deaths were not really recorded as deaths in the hospital system. But when they went home, each death is recorded in a commune-level vital registration system. So that system is maintained by the commune where they go to each household. They have workers that go into each household and record each and every death happening in the community. For road traffic injuries, there has been a study done, and that found that this system is pretty valid and pretty accurate in capturing those deaths. Here is a graph that shows the road traffic fatality rate that we obtained through this commune-level A6 vital registration system over the years of the project. So the project started in 2010. As you can see in the two provinces that were the focus of this project to begin with, we have seen a decline in the road traffic fatality rate in Vietnam through this system. The second lesson we learned is that it was very important for us to have multiple rounds of observational studies and collect more data than just the overall prevalence of the risk factor. Here I'm going to use some of the data we've collected in Kenya to illustrate this point. Now, just a brief overview of Kenya road traffic injuries. As per the Global Burden of Disease study, the 2010 update, accounted for over 400,000 years of life lost due to premature mortality. And therefore, the project there focused on two sites, Thika and Naivasha. And the targeted risk factors for Kenya were helmet use, including reflective clothing use, as well as speeding. And the intervention consisted of four components. There was a social marketing campaign that was held, enhanced enforcement. The partners tried to change legislation and improve legislation in Kenya, as well as a focus on trauma care that you've already heard about. In terms of data collection, we did observational studies in Kenya for both risk factors. We had knowledge, attitude, and practice surveys, as well as focus group discussions, and we were also able to implement one round of community-based household surveys in the two sites. Now, here is a graph that shows the prevalence of compliance to the speed limit in these two sites. So we were able to do speed observations every quarter in Kenya, where we had randomly selected sites across these districts, and we had our teams standing with speed guns recording speed at different times of the day on different days of the week. And what this shows us is that speed compliance has gradually been going up in these two sites. Obviously, we have fluctuations from round to round, but the general trend is that speed compliance is inching upwards. On this graph, we also have all the interventions that have taken place, the social marketing campaigns, and the distribution of speed guns when the police started using them, These are in black boxes. We have external activities that took place in the red boxes here. That's the general election that took place in Kenya in March 2013. But it's important for us to go beyond just this main one number of speed compliance and see what is responsible, what underlies that number. So we were able to disaggregate this data by the type of vehicles that were passing through. And we found that among the least compliant vehicles in one of the sites, that is, for example, Thika here, trucks and matatus were usually the least compliant. So that gives us more information to be able to present to our implementing partners in terms of what areas they could focus on. Given this information, we also found that it was important for us not to rely just on one type of methodology and to employ a mixed methods approach to understand what the underlying factors were behind this speed compliance that we were seeing in Kenya, for example. And so, as I said before, we were able to implement knowledge, attitude, and practice surveys in each of these sites. And in Kenya, for example, we found that the top factors that were related to people's decision to speed or not were depending on traffic. So if the traffic was if there was pretty high traffic, then they couldn't speed. Or whether or not they were in a hurry to get somewhere. But we also found from these surveys that the proportion of individuals who knew the speed limit at the point where we were interviewing them, these interviews were done at the roadsides, increased significantly in Thika, for example. We started at 34% of our respondents telling us that they knew the speed limit, and as of the 6th round, we were at 80%. This number started off pretty high in Naivasha, and it has remained at that point. We were able to also employ some qualitative studies. So here are some a quote from one of our focus group discussions with drivers of matatus. We found that matatus were most responsible, were the least compliant to speed limits. And one of the reasons they told us they tend to speed is that because these matatus are usually not, these are 14 passenger taxis that ferry people from town to town. And they're not owned by the drivers. Their boss, the driver's boss, gives them a target amount that they're supposed to, of revenue that they're supposed to collect in a day. And anything they make beyond that is usually theirs to keep, which is why they tend to speed so that they can make more money. We also found that external activities happening around the country have an impact on what happens to the results from the program, or how activities are implemented as part of the program. And this I'm going to illustrate using some of the data that we have from Cambodia. It is important for us to keep track of those external activities because that helps us understand why we weren't seeing an improvement, for example. So Cambodia is a low-income country. The targeted provinces in Cambodia were 6. And the capital was part of that. And these 6 provinces cover a population of almost 45% of the population in Cambodia. The risk factors that were targeted as part of this program in Cambodia were drinking and driving and helmet use. And here is a graph that shows the yellow bars are the total number of fatalities, and the blue bars here are the number of motorcycle fatalities. So you can see here that the motorcycle fatalities represent a big proportion of the total fatalities seen in Cambodia, and thus the focus on motorcycle helmets as one of the risk factors. Here is a brief snapshot of all the data that we collected, the primary data that we collected in Cambodia. In Cambodia, we were able to do helmet observations every other month, so we had 18 rounds of observations as of the end of 2013. And drinking and driving was the same case. We were able to collect data on that every other month as well. We did KP interviews for both risk factors, and we had 7 rounds of those. Now, this is a graph that shows helmet use in Cambodia. This is a very interesting graph. The red line here is helmet use among passengers, and the blue line represents helmet use among drivers. As you can see, there's a big difference between drivers and passengers. One of the reasons for this is that the legislation in Cambodia does not mandate helmet use for passengers. The other thing that we see in this graph was that despite early wins at the beginning of the project, so for example, at the beginning of 2011, we were seeing helmet use increase, but towards the end of the year and throughout the rest of the project period, we've seen helmet use decline. And we started asking ourselves the question as to why this was happening. Because initially when we started the project, in the first few months, we were very excited. We were because we started off at 60%. So if we continue that trend, we would be we would do quite good by the time the project was over. So here comes, and this is helmet use among drivers in 5 provinces, 5 of the 6 provinces, which shows in further detail what was happening to helmet use. So as I said, it was important for us to see what else was happening. And these red boxes mark external activities that were happening beginning in September 2011, where some of the enforcement was impacted due to weather conditions. So there was floods in a couple of provinces towards the end of 2011. In 2012, there were some local elections which impacted enforcement as well. In late 2012, the king passed away, so the enforcement was affected because the police had to be involved in preparations and security for the king's funeral. And throughout 2013, we had a general national election in Cambodia where enforcement had totally stopped. This tells us that all these external activities impacted enforcement, and because of lack of enforcement, we basically lost, and in fact, we're headed in the wrong direction in terms of helmet use in Cambodia. Another lesson that we learned was that it's important to correlate observed trends in risk factor prevalence to outcomes. So if we're seeing an increase in risk factor prevalence, are we also seeing a decrease in, for example, fatalities? So again, this is an example from Cambodia, and this example focuses on the first few months where we were seeing a positive change in Cambodia. On the left of the screen is a graph that shows helmet use among drivers in, now this is overall helmet use in Phnom Penh. And on the right is a graph that shows motorcycle casualties with head injuries in Phnom Penh. As we can see here, with an increase in helmet use, head injuries are going down in Cambodia. Now, you should remember from the previous graphs that helmet use was higher among drivers than it was in passengers. And this graph here shows us that fatalities, sorry, these are head injuries again. Head injuries were going down among drivers, and they remained unchanged among passengers. So that shows us that if we were to continue increasing helmet use, we would really start seeing an impact on head injuries and subsequently fatalities. As I mentioned briefly before, we also found that enforcement is key for sustained behavior change. And I'm going to use some of the data we have from Cambodia and Kenya to illustrate this. We found that, you know, while you may be able to increase knowledge about behavior through social marketing campaigns, you really need something else that's happening alongside with those social marketing campaigns to be able to sustain the behavior change or to effect behavior change. And these are results on helmet use from Cambodia. And we asked people what the top 3 reasons were that they decided to wear helmets. And here we can see from this graph that in almost every round that we collected this data, we saw that people understood the life-saving potential of helmets, and which was the top reason why they decided to wear helmets. I mean, we were almost at saturation at one point at 98.4% in May of 2013. But we see that only small proportion of people report that they wear helmets because of police fines. And if we were able to increase enforcement and the perception of regular enforcement among the population, we would be able to see an increase in helmet use. This is another graph from Kenya showing similar results. We see that people here too understood the life-saving potential of helmets. I mean, we were at 92, 93% in both sites. But again, a small proportion decided to engage in that behavior of wearing helmets because it was required by law. So that tells us social marketing could focus their messages around what the law requires, as well as have concurrent enforcement to be able to sustain that behavior. We also saw this in our focus group discussions. This is a quote from Kenya, and I'm just going to read it. These are community members in Naivasha who said that there's only one thing we can do. Traffic police are the first people to curb overspeeding because they are the ones that do patrol and know which vehicles are overspeeding. If they are determined, they can easily curb overspeeding. So multiple methodologies combined give us this message that enforcement is really key when it comes to effecting change in these risk factors that we were trying to address. We also found that no one methodology was enough to be able to capture what was going on and to be able to understand these changes that were happening as part of the program, and therefore we needed to employ robust methodology. We needed to standardize protocols across countries to be able to make cross-country comparisons, for example. We needed multiple methods, mixed methods approach, and triangulation of data. As I mentioned before, we had multiple secondary data sources, so we needed to make sure we were bringing these data sources together in a way that would give us a more complete picture. We needed large sample sizes, which was possible due to our observational studies, which allowed us to make more concrete conclusions and inferences from our data, as well as multiple rounds of measurement, which allowed us to track the trends of risk factors over time. A big lesson we learned is that you really can't do this alone. We really can't go in as Johns Hopkins International Injury Research Unit and start collecting all this data alone. We needed to establish collaborations. We needed to identify key partners in each of these countries. Many of our partners are here in this room today, where we did this work together right from the beginning. We planned these methods together, we developed these instruments together, and we developed a mutual sense of trust between these two parties. And this engagement went even beyond just us and our local collaborators. We had to build trust between the different agencies that did supply us with the secondary data sources, because there's a sense in most low and middle income countries that people from high income countries will just come, we'll give them our data and they'll run away with it and we won't see any change in our countries. So we had to face that at the beginning of the project, and in many cases we were able to overcome that. We found that we were able to create and strengthen some of the networks for road safety at different levels. At the global level, all consortium partners came together to work as a team. At the national level, we had different agencies come together who formed part of the national coordinating committees, as well as the local district levels where that was happening. And throughout this process, it was important to develop capacity such that these activities are sustained even beyond the 5-year time frame of this project. I'm going to end with some of the strengths, challenges that we faced, as well as just leave you with a few words about where we're headed after this. So strengths to our monitoring evaluation work, we found that we were able to build good working relationships, good personal relationships, as well with local collaborators, as well as consortium partners. We were able to develop data collection mechanisms and establish them in all the 10 countries. These were among, as many of you might know, these were amongst the first studies on risk factors for road traffic injuries in many of these countries. This data was previously unavailable in many of the countries. We were able to collect very large sample sizes and multiple rounds of data collection. As such, we were able to generate some good evidence that can be used to enhance or to the field of road traffic injury prevention. And this evidence was not only useful for the donor, but for the field as a whole. We were able to say what the number was in terms of, for example, prevalence estimates for many of these risk factors and why those estimates were or were not changing. We were able to refine our data collection methodologies and mechanisms. It was important to have data collection methods, but also important was how we were collecting that data. Were we using paper forms? What were the limitations with those? And through this project, we were able to experiment some electronic forms of data collection where we can now get real-time data coming to us. Some of the challenges in our work were obviously, one of the main challenges was related to secondary data, where we faced delays in receiving some of this data from different countries. Many times, different data sets have conflicting information. For one of our risk factors, we found the biggest challenge was collecting that data on drinking and driving, where in all countries that we were trying to collect data on that risk factor, we found that we didn't have permission to conduct independent studies because of either legal issues, sociocultural issues, as well as personal safety of our field staff. While we find that there's optimism around social marketing, there's limited evidence of social marketing to affect behavior change. As I mentioned a few minutes ago, social marketing, while is good at changing knowledge about a practice, it really needs to be coupled with another reinforcing mechanism to affect behavior change. So it's important for us to learn what is meant by social marketing, when these social marketing campaigns are done, and who the audience or target is. In terms of next steps, we plan to continue analysis of our observational data to see what the trends are. Some of this data is still being collected through the end of the year. We plan to do some cross-country analysis. These analysis could prove potentially powerful in terms of teaching us useful lessons across different sites that could be applied for the future. We are trying to see if we can estimate how many lives have been saved as a result of this program, and also a study on understanding the long-term consequences, health, social, and economic consequences of road traffic injuries. With that, I thank you and look forward to your questions during the discussion.